The following podcast is part of a certified educational activity titled Frameworks for Identifying and Addressing Systemic Sclerosis and Its Complications from Pathophysiology to Personalized Care. Access the entire activity and complete the post-test at peerview.com/TCA860. Downloadable slides and practice aids are also available.
Hi, everyone. Welcome to this educational activity titled Frameworks for Identifying Systemic Sclerosis and Its Complications from Pathophysiology to Personalized Care. My name is Dr. Elizabeth Volkman, and I am the director of the UCLA Scleroderma program. Today, we have a number of goals. During this presentation, we will learn that there are distinct pathophysiological mechanisms that underlie SSC and contribute to both disease onset and progression. We will also discuss early recognition, accurate classification and risk stratification, and how these are essential to optimizing outcomes for patients with SSC. We will review current and emerging therapies that target different pathways in SSC, offering new opportunities for personalized medicine. And finally, we will discuss comprehensive team-based care approaches that can address the multi-system nature of SSC and, most importantly, improve patient quality of life. So let's jump right in. There are a number of different clinical manifestations of systemic sclerosis, and this is a disease that can be highly unique in every single patient who you see. And these are some of the common manifestations that we see across many patients with systemic sclerosis, but this is not an inclusive list. So one of the things that we often see early on in patients with systemic sclerosis is hand swelling and puffiness. And what this is it's a little bit different than a disease like RA, where you might see swelling in specific joints. In this, you'll actually see swelling of all the digits and even the hands. And it might be subtle at first, and a patient might notice that their rings aren't coming off quite as well, or they can't make such a big grip. But sometimes this goes unnoticed to healthcare providers because the swelling is diffuse. So in this case, you'll want to look at the hands, but you also want to talk to patients and just ask them, is it harder to make a fist? Is it harder to get your rings on and off? Are you having any difficulty using your hand? Because the early signs of hand puffiness might not be so visible to you, but a patient might be impacted in terms of their life. Lung involvement occurs in most patients who live with systemic sclerosis, and there's a number of different studies looking at the prevalence of something like ILD, and in different cohorts it can vary, but on average it's about 65% of patients. So because it's such a common manifestation of systemic sclerosis, you'll want to screen all your patients with SSC for something like ILD with a high-resolution chest CT. Usually when a patient is diagnosed with systemic sclerosis, they will have interstitial lung disease if they're going to have it. So if you do a CT at the time of diagnosis, it'll be really high yield. However, there's some important data that has recently emerged showing that patients can develop ILD that's clinically apparent later in the course of their disease. And there was a study, for example, that came out of a group in Canada where they found that about 20% of patients developed incident ILD more than 7 years after the onset of the first non-Raynaud symptom of systemic sclerosis. So I mention this because even if a patient does not have ILD at the time of their SSC diagnosis, you'll always want to be monitoring patients for the development of ILD in the future, again, if they don't have it at that first diagnosis. What about GI issues? This is something that largely impacts patients' quality of life, and it affects basically every patient with scleroderma. And it might be that these patients have subtle symptoms early on, so a little bit of reflux or heartburn, or a little bit of distension, bloating. But as scleroderma progresses and as a patient lives longer with this disease, the GI symptoms can really take over and become a huge problem for patients. So things like fecal incontinence, chronic diarrhea, chronic constipation. These are not only symptoms that drive people to go to the doctors, but it forces them to change their whole life. Some patients will avoid going out to eat or going to social gatherings. They might avoid taking long car rides or traveling on a plane because they're worried about GI symptoms, especially this fecal incontinence. And this is something that a lot of patients might not even feel comfortable telling you. So it's important as a provider to ask your patients about their GI symptoms. We're also learning that these symptoms can occur even before sometimes a patient notices Raynaud's or puffy hands. So sometimes I find that patients are misdiagnosed as having something like irritable bowel syndrome years before they come to see me, but really this was probably early scleroderma. RENA involvement occurs in about a quarter of patients, and namely, the most well known manifestation is something called renal crisis. This used to be the leading cause of mortality in patients. So, before we discovered that ACE inhibitors can help treat renal crisis, many patients who developed this manifestation of scleroderma died. If we can detect renal crisis early and treat patients, they can do quite well. But there are some patients that will go on to need dialysis and have end stage renal disease, require a renal transplant if their renal crisis is not diagnosed and treated effectively early on. Raynaud's affects almost all patients with scleroderma, but there's a spectrum of symptoms that patients can experience. So sometimes patients have very mild symptoms that are just sort of a daily nuisance, and if they wear their gloves and keep their hands warm, they're okay. But there are other patients where the Raynaud's can be debilitating and they can develop digital ulcers, and this can be extremely painful and limit their ability to use their hands. There's different triggers for Raynaud's, and for some people, the cold is a big trigger, but for other patients, stress is a trigger. So when you're stressed, your sympathetic nervous system gets activated, and this actually causes vasoconstriction of the blood vessels in the hands and feet. So I find that some patients get really frustrated because they might be on medications for Raynaud's, they might be keeping their hands warm, and they still have a lot of symptoms. I try to review stress with them as a trigger because sometimes that's the culprit. Cardiac involvement is something that also occurs in about a quarter of patients, and there can be different cardiac manifestations. So, some people can get fibrosis or scarring in the muscle of the heart, and this can lead to arrhythmias because you don't have a good electrical circuit in the heart. This can cause sudden death in patients, so it's a really serious problem. Other patients can have things like cardiomyopathy, they can have valvular issues as it relates to scleroderma, and it's really important for these patients to involve a cardiologist early and do appropriate imaging to diagnose the cardiac involvement. Muscle and joint and pain can affect a lot of patients. So, in terms of the muscles, patients who have early diffuse skin disease can have what's called a myopathy. So, they might have a mild increase in inflammation in their muscles, and this will manifest as slight elevations in their CK and aldolase levels. But then you'll have some patients who have a true overlap with myositis, and their CK levels will be extremely high. Usually in the first case, the myopathy, these patients, it'll get better over time with treatment of diffuse skin disease. But if they have a true myositis, they're going to need treatment for that as well. Patients can have joint pain, and this can be arthralgias or even arthritis. And we do see that patients can have an overlap with something like rheumatoid arthritis. Calcinosis is a really troubling symptom that unfortunately we don't have great treatments for, but the calcium deposits can occur in different parts of the body, especially the hands, overlying the joints. And what we generally find is that when you improve the treatment of Raynaud's for these patients, it can sometimes help their calcinosis, but some patients will require surgery and other types of treatments to clear the calcinosis if it's causing a lot of disability and pain. Skin thickening and color changes of the skin are really the hallmarks of this disease, and you're going to direct a lot of your therapy to this. And then we already talked about digital ulcers, again, as being sort of a severe manifestation of having Raynaud phenomenon. These symptoms can converge to have a large impact on quality of life over time. And in this slide here, we're looking at different measures of quality of life and how they can decline over time for patients. So, both Raynaud symptoms, digital ulcers, and GI complications tend to have the largest impact on quality of life. Worsening of mouth opening, the 6-minute walk test, and hand function can also contribute to decreased quality of life. And then in patients who have long-standing disease, things like pulmonary arterial hypertension can also decrease health-related quality of life. There's also a risk of premature death in patients with systemic sclerosis. And of all the autoimmune connective tissue diseases, systemic sclerosis has the highest cause specific mortality. And in this figure here, we're looking at the survival rate comparing patients who have diffuse cutaneous disease and those who have limited cutaneous disease. And for those of you who are unfamiliar, we categorize patients based on the extent of skin involvement. So if a patient has involvement from their elbows down, their knees down, and their neck up only, they will have limited skin disease. If they have any involvement of their thighs, their upper arms, their chest, or their abdomen, they're labeled as diffuse skin disease. So you can see in this figure that those patients who have diffuse skin disease, which is the solid gray line, tend to have worse survival. But clearly, those patients with limited skin disease also can have premature mortality. There are other factors that can be associated with worse prognosis in SSC. So, besides having this diffuse skin disease, we know that patients who are older age, specifically over the age of 60, have a worse prognosis. There's also other clinical features that can portend a worse prognosis, including telangiectasias, the presence of sclerodermal renal crisis, when people start to have severe dyspnea, based on class 3 and class 4 New York Heart Association criteria, when patients have diminished 6-minute walk test distance or greater restriction on their pulmonary function testing. Just the presence of PAH alone can lead to a worse prognosis, along with valvular disease, anemia, elevated CRP or inflammation in the blood, and then finally cancer. In terms of what causes systemic sclerosis, we actually don't know the single cause of systemic sclerosis, but we have a good understanding that this disease occurs in patients who might be susceptible. And they might be susceptible for different reasons. They could come from a family who has a long history of autoimmune disease, so they have a genetic susceptibility, but there can be environmental factors that can also increase a patient's risk of getting systemic sclerosis. But then something triggers the onset of this disease and causes this perturbation of the immune system, which can cause inflammation, vasculopathy, and fibrosis. And this is sort of a circuitous process where one can exacerbate the other. And over time, with added inflammation, fibrosis, and vascular changes, patients can get organ damage, and this can cause symptoms. There's a large unmet need to develop therapies for patients that target these different aspects of their immune system. So we currently have some therapies that target inflammation, but we really need our patients having therapies that would target all of these aspects of their immune system. In terms of the major cell types that are involved in systemic sclerosis, obviously the myofibroblast is a very important aspect of this disease because this is going to contribute to fibrosis or scarring, which is the pathological hallmark of scleroderma. But we also know, for example, that adipocytes can play a role, and there is something that can happen where adipocytes or fat cells can transition into fibroblasts. In addition, we know that the adaptive immune system play a key role in this disease. These are your B cells, and these are the cells that produce antibodies. And we'll talk a little bit more about key antibodies in patients with systemic sclerosis. And then finally, the endothelial cells. These are the cell types that can contribute to vasculopathy. So this is just an overview of the major cell types that can be involved in the pathogenesis of systemic sclerosis. In addition, if we look deeper again at these endothelial cells, we know that there are periocytes as well as platelets that can also be affected in patients with systemic sclerosis. This can lead to increased production of these adhesive molecules, which are listed here. The proliferation of vascular cells, which you can see by this figure, will help limit blood flow to areas. And this is one of the key reasons that patients can get Raynaud's in their hands and feet, and also in their organs when they're not getting enough good blood flow. And we think that this can even affect fibrotic pathways because we know that blood flow is important for preventing fibrosis. The soluble guanylate cyclase pathway is a pathway that you may remember from medical school, but this is a pathway that's involved in different aspects of immune function. And particularly, it's affecting cyclic GMP. And this is involved not only in nitric oxide production, which can cause vasodilation, but it's also involved in blocking fibrosis as well as inflammation. So, in terms of a therapeutic target, this is an attractive target because, again, it's getting at all of the different pathological aspects of systemic sclerosis. Let's think about the latest evidence, though, in terms of diagnosing this disease, assessing someone's risk of progression, and then how we monitor patients with this condition. And I'll start off with a case because I think this is a nice way for us to review a real life case of a patient with systemic sclerosis. And this is a case that you might see almost every day in your practice if you work as a rheumatologist. So, this is a patient, a 35-year-old Latina woman. Here we've named her Sophia, but that's not her real name in real life. And she presented initially to her PCP with fatigue, body pain, as well as Raynaud phenomenon that she'd had since she was a teenager. And she was found by her PCP to have a positive ANA at a titer of 1 to 320, which is a moderately high titer ANA. So, when you see a patient like this, it's important to consider three factors when you're deciding what is the likelihood of systemic sclerosis, right? Because this patient has very nonspecific complaints. She has a positive ANA, which is not specific for scleroderma. And so she could have other autoimmune diseases too, such as lupus, such as RA. So, the first thing you'll want to do is assess symptoms like Raynaud's, and you'll want to understand the onset or worsening of these symptoms. And I mention this because most people who get Raynaud's as an adult are more likely to have the Raynaud's be secondary to a connective tissue disease. But in this patient's case, she's had it since she was a teenager, and so it was probably Raynaud's. But if the Raynaud's starts to worsen and become very problematic, it could be turning into secondary Raynaud's, that is, Raynaud's secondary to a connective tissue disease like scleroderma. You'll want to perform a physical examination, and as part of that physical examination, you'll want to examine the nail fold capillaries because there can be key changes on capillaroscopy in patients with very early scleroderma to give you a clue that this is not primary Raynaud's, this is secondary to connective tissue disease. Even if the hands don't have swelling everywhere, if they're a little bit puffy or a patient tells you they can no longer get their rings on and off, again, this could be a clue of early scleroderma. And then finally, this is when you'll want to order a comprehensive scleroderma antibody panel. So this is going to be a panel that will test for a number of different antibodies that are associated with systemic sclerosis. And we do this because not only it can help with the diagnosis of SSC or very early systemic sclerosis, but it can give you key insights into a patient's prognosis. And so when you do this, you'll get some information that can be helpful. And there have been studies that have looked at patients long-term with Raynaud's and assessed the risk of developing definite systemic sclerosis. So if a patient has Raynaud's, they have a scleroderma pattern on capillaroscopy, and they have one of these scleroderma-specific autoantibodies, they actually have about a 70% chance of developing SSC in 5 years. And it could be even higher as we go further out. But if a patient just has Raynaud's, has normal pattern on capillaroscopy, no SSC-specific autoantibodies, there's only about a 1% chance that they will develop definite SSC in 5 years. So this is really critical because you can offer your patients a lot of reassurance if they have this normal pattern on capillaroscopy and they have no scleroderma-specific autoantibodies. In terms of the specific autoantibodies, this table lists the common ones that are checked for on these comprehensive tests that you can order through major commercial labs such as Quest or LabCorp. And you'll see anti-topoisomerase. This is also referred to as anti-SCL70. And then in this table, this comes from a review article where the author looked at the prevalence of these autoantibodies in different areas throughout the world. And you'll notice that in some of these, like the ones listed further below, they don't really have good evidence because they're often not checked for in every patient. but we do have fairly good insight into the anti-SCL70, the anti-centromere, and anti-RNA polymerase 3. And so what you'll notice is that some of these antibodies are more prevalent in certain parts of the world. So, in terms of your patient, going back to this case, if you have someone who has Raynaud's, if they have puffy fingers, if they have the ANA antibody, you'll want to do the capillaroscopy and check the serologies. And if any one of those is positive, the capillaroscopy or the serology, this patient can actually be classified as having very early systemic sclerosis, and we call this VITOS. And at that time, you can actually investigate them for organ involvement related to systemic sclerosis. But if both are negative, you might want to reconsider, does this patient have another ANA associated autoimmune disease? And just follow the patient along to see if something evolves. So let's come back to our patient, Sophia. She actually was found to have a positive SCL70 antibody. She had abnormal nail fold capillaries as well as puffy hands. So right away, we know this patient at least meets criteria for very early systemic sclerosis. But we went a step further. We got the CT of her chest, pulmonary function test, and echo and upper endoscopy. Now, you may think, is this too aggressive for a patient with very early systemic sclerosis? And I will tell you no, because if you wait until a patient develops symptoms of lung disease, let's say, their lung disease will already have advanced to a large degree. You'll want to assess organ involvement even before a patient complains of symptoms, because this can not only, again, help with your diagnosis, but it can help you in personalizing the treatment for the patient. So in this patient, we got a high resolution chest CT. And what you can see here is this patient has early interstitial lung disease. She has some ground glass opacity. She has some reticulation in an NSIP pattern, which is the most common pattern we see in systemic sclerosis. In addition, we got pulmonary function testing, and both her FVC and DLCO were 88% and 79% predicted, respectively. So the DLCO was slightly lower, and the FVC was slightly above the normal range. But keep in mind that when you're interpreting these results, you actually don't know what the patient's PFTs were 1 to 2 years ago in most cases. So this patient could have had an FVC of 100% or 110% 2 years ago, and now she has declined. Fortunately, the patient did not have any abnormalities on her echo or on her upper endoscopy. So, if we look at the classification criteria for systemic sclerosis here, you can see that this patient actually meets criteria for definite systemic sclerosis. So, she doesn't just have very early systemic sclerosis. Because she has ILD, she actually gets points for that. So, she got 2 points for having puffy fingers, 2 for the abnormal nail fold capillaries, 2 for ILD, and 3 for the SCL70 antibody, leading to a total score of 9, which again will classify a patient as having systemic sclerosis. Let's go into another case here. So, that first case was sort of highlighting how we can diagnose this disease early and get patients on the right path towards recovery. But we also can have patients that might come to you that already have systemic sclerosis, and you're going to try to understand what is their risk for progressing and how do I monitor this patient appropriately. Really, every patient who lives with an autoimmune disease, including systemic sclerosis, is unique. But there are some features that, again, can help you predict what will happen in the future for the patient. And it's always better to get on top of these symptoms early. So, this is another patient, Kevin, a 42-year-old Caucasian man with diffuse systemic sclerosis. He actually had a positive RNA polymerase 3 antibody, and he already had ILD on CT, but it was a pretty mild extent, only 5%. So, when I think about patients with systemic sclerosis and I'm trying to understand their overall risk of getting certain manifestations or progressing over time, I'm looking at demographics. So, we know that men with systemic sclerosis are more likely to have diffuse skin disease and ILD than women. And when they have ILD, it typically follows a more progressive course, both with and without treatment. Older age is also associated with progressive ILD. And then we know that in the US, African American patients tend to have more progressive ILD, and this is based on observational cohort studies. Autoantibodies, again, give us information not only to help us diagnose this disease, but also to predict prognosis. And when people have the SCL70 antibody, they're more likely to have diffuse skin disease. They're also more likely to have ILD, and typically the ILD has a progressive phenotype. If people have the centromere antibody, this is actually protective for ILD progression. So these patients can get ILD, but it usually does not progress, although it can. Also, they tend to have more limited skin disease. And then lastly, the RNA polymerase 3, these patients are more likely to have diffuse skin disease as well as renal crisis. They're also at higher risk for malignancy. Here's again another review of the different autoantibodies that come on that comprehensive scleroderma antibody panel that I told you about. And what's nice about this figure is that we've divided things into diffuse patients, limited, and overlap. So the overlap is in the purple below. And what do I mean by this? This is patients who will have systemic sclerosis, but they'll also have features of another disease like myositis. So if a patient has one of these autoantibodies that's in the purple back, you want to make sure you're looking out for myositis in these patients. So even if they don't complain yet of muscle pain or weakness, you'll want to check that CK level in their blood. You'll want to check the aldosase as well. So let's get back to our case. Kevin, this was a male patient. So we're thinking about progressive ILD, diffuse skin disease. He's under 65, so that's protective in terms of age. He's Caucasian, so again, protective compared to African Americans in terms of ILD. And then he has this RNA polymerase 3 antibody, which is associated with diffuse skin disease, a risk of renal crisis, and also risk of malignancy down the line. So when I look at this patient, I'm clued in. Already I know they have lung disease. I need to monitor this closely. We know basically that all patients with scleroderma get GI issues, so I'm going to be following that very closely in this patient. Because they have the RNA polymerase 3 antibody, I'm going to be looking out for renal involvement as well as the diffuse skin disease. So here was our plan for Kevin. We wanted him to monitor his blood pressure every day at home. And this is because one of the earliest signs of renal crisis is slight elevations in blood pressure over time. We'll see him every 3 months in the clinic where we'll do a skin score assessment. We call this the MRSS or Modified Rodnan Skin Score. This too is to assess how his skin is changing over time. We'll also get pulmonary function tests every 3 months to assess the progression of his ILD. And the reason we do it every 3 months is we really want accurate trends in these measures. If you just do the PFTs once or even twice a year, sometimes patients can have a bad day. They might have a cold, or there might be a different technician in that day, or they might have to go to a different PFT site. And there can be variations in pulmonary function testing based on factors outside of the lungs, like the ones I just mentioned. But if you have 3 to 4 measurements over the course of a year, even if you have one that's a little bit off because the patient was sick, you're going to be better able to see trends in their pulmonary function. We'll get labs every 3 months and then a CT and an echo every year. And specifically, while this patient is undergoing treatment for ILD, let's say, we want to get that CT because it's going to give us information about whether the treatment is working or not. There are definitely guidelines available that have been developed in recent years for managing and monitoring SSC. So I wanted to call your attention to a recent one that was published last year by the British Society for Rheumatology. And basically, the important thing for you to notice here is that there are initial management approaches. So you're going to look at skin, you're going to look at a patient's Raynaud's. You want to investigate them for GI function, especially upper GI function like reflux disease, lung, and other features. So if you're a general rheumatologist, this is really the key part of this figure for you. Doing these investigations early on to not only diagnose scleroderma, but understand the multiple ways it's affecting patients. Because once again, patients might not have symptoms of reflux or lung disease, but they could still have it. And the only way to know is to do these investigations. There are some limitations, though, of our current risk assessment. So we rely a lot on these clinical features. So someone's sex, someone's race, autoantibody status. But again, in the real life patient, they'll have some factors that might be protective and some that might be associated with risk. So when we take our patient Kevin, for example, he was a younger guy, so that's better, but he was a male, and we know that that's associated with worse skin disease. So we really need to do a better job of developing more holistic risk assessments so we can understand having one risk factor for progression, how that affects someone when they have another factor that sort of protects them from progression. So, I'm going to transition now into talking about our available and emerging treatment options for SSC. And this is a really exciting time in systemic sclerosis. When I started training in this field, there were actually no approved therapies for systemic sclerosis. Now we have some approved therapies, but more importantly, we have a lot of trials in progress for discovering new therapies for our patients. So when we talk about, starting any treatment for the patient, it's really important to involve the patient in this process. Most people that I meet who live with autoimmune diseases, including systemic sclerosis, are well informed. They go on the internet, they join support groups, they're on blogs, they're trying to get all the information they can to make informed decision. And if you're a provider for one of these patients, you want to really make sure that they're treated like an equal in this decision making process. So you'll look at them from a doctor's perspective, you'll assess their clinical status, you'll review all the evidence that's available, but you really want to reach consensus with the patient and make sure they're involved in the treatment decisions. And in order to do that, you want to explore what their goals are, what is important to them. And I always ask patients, what is your intention coming here today? Some patients might want to be able to keep working for a long time. Other patients might be able to want to keep caring for their family, or if it's an older person, they want to be able to pick up their grandchild. But if you don't understand their values, you might have different goals than the patient. And the key is to reach this consensus when you're working together to develop a treatment plan. In 2023, EULAR actually issued some very comprehensive guidelines on the management of systemic sclerosis. And what's great about these guidelines is they're not just focused on skin or lung, but they're actually really trying to tackle the multiple different clinical dimensions of this disease, ranging from how we manage Raynaud's and digital ulcers to how we treat GI disease and renal crisis. And I will just say that some of these guidelines are expert opinion and others are based on randomized controlled trials. So again, some of this is going to be based on someone's personal opinion, but if you look, for example, at the interstitial lung disease clinical manifestation, most of that is based on real evidence from clinical trials. In terms of going deeper, in this guideline, they look specifically at the treatment of Raynaud phenomenon in digital ulcers. And so for this, they recommended starting with an oral agent like a calcium channel blocker, and this could include nifedipine. And if a patient has control of their symptoms, you would continue it. But if they don't have control of their symptoms or they develop a digital ulcer, you could consider escalating therapy to something like a PDE5 inhibitor. This is something like sildenafil or tadalafil. This can help sometimes with the healing of ulcers, or even something like bosantin, which is an endothelial receptor antagonist. What about pulmonary arterial hypertension? Again, this is a major contributor to morbidity and mortality and over time in patients. And there are specific therapies that have been approved for patients with PAH due to systemic sclerosis and other causes. These, again, can include things like the endothelial receptor antagonist, the PDE5 inhibitors, but there's also higher level drugs like prostacyclins that can be helpful. And for these patients, it's really critical to manage them with a pulmonologist or cardiologist who has a specialty in managing patients with PAH. For the ILD treatment, for patients who are already on mycophenolate, which is often considered the first-line therapy for scleroderma ILD, there can be escalation options, and these could be adding on nintedanib with or without mycophenolate. It could be switching them or adding on rituximab or cyclophosphamide, or even considering something like tocilizumab in a person who has early inflammatory features. There were also guidelines that were published a year ago by the American Thoracic Society, and this was an evidence-based guideline, so mostly based on clinical trials, less expert opinion, to try to understand how to treat SSc-ILD. And the consensus from the group was that mycophenolate had the most evidence strongly in favor for treating SSc-ILD. There was conditional favor for cyclophosphamide, rituximab, tocilizumab, nintedanib, as well as the combination of nintedanib plus mycophenolate, and then a research recommendation, meaning more evidence is needed to support whether or not to use pirfenidone in this disease. In terms of our emerging agents, Avensicquat is one agent that we're excited about, again, because it targets the soluble guanylate cyclase pathway. So when I started this talk, I mentioned to you that this pathway is important not only for inflammation, but also for vasculopathy and fibrosis. And so Avensicquat is likely to have protective effects in terms of vasculopathy, but also important antifibrotic effects as well. And there is a phase 2 study that's ongoing called Vitalize SSC. And this is a trial comparing Avensicquat dosed 3 times a day to placebo. And in this study, the target N is about 100 patients, and it's being conducted throughout the world. It's a study where the primary endpoint is looking at the forced vital capacity, or FVC, at 48 weeks, but then patients will be followed beyond that time point, which is pretty standard for a clinical trial. There are very nuanced eligibility criteria for this trial, but the biggest important points here to consider is that this trial is looking at adult patients who meet the classification criteria for SSC. They have to either have diffuse skin disease, or if they have limited skin disease, they will have to have the SCL70 antibody. In addition, they want people that have had the disease for a shorter amount of time, so at least must be within 7 years from the onset of their first non-Raynaud symptom. And then you'll see here below in this figure other indicators of active disease. And so in this sort of approach, you'll be able to kind of choose, okay, does the patient have an elevated CRP? Do they have new involvement of skin disease? And this is where, again, those criteria become nuanced. But the bottom line is the study is looking at patients with relatively early systemic sclerosis who have signs of active disease, either in terms of their skin getting worse or their lung getting worse, or they have inflammation in their blood. The primary endpoint, as I mentioned, is the forced vital capacity and looking at the rate of decline of FVC over 48 weeks. But there's some really key important secondary endpoints in this trial, and they include the skin score, so looking at how this drug affects skin disease, also looking at a composite measure called the revised CRIS, which takes into account quality of life components, and then the HAQ-DI, which is the Health Assessment Disability Questionnaire, again, looking at how the disease affects hand function and other aspects of disability. And then I won't list all these secondary endpoints, but I wanted to mention them here because, again, we're really concerned in these studies, which not only how the FVC changes or the MRSS, but we really hope to make patients feel better with our medications. So this trial will help answer those questions by looking at a lot of different patient-reported outcomes over the study. So what would be the potential role of Avensicquat in treating systemic sclerosis? It could address core physiological drivers of SS3 through enhanced nitric oxide, independent cyclic GMP signaling, but again, it might also affect in lower oxidative stress and hypoxia, and could have even broader therapeutic utility, meaning that it might help other patients with ILD due to things besides systemic sclerosis. Because we think that it could be first line or add line therapy, it's important for us to understand how this drug works both with and without background therapy like mycophenolate. And bottom line is that this might even have an effect on Raynaud's. And this would be a major win because we currently don't have many options for Raynaud's besides the agents that I mentioned, the calcium channel blockers and PDE5 inhibitors that don't really work for all patients. There are important emerging therapies that are on the horizon and under study, and here are just a few. This is not completely comprehensive, and I would say this list is changing every day as new trials open. So there are phase 2 and 3 studies ongoing looking at different medications. Some of these are biologic medications that are being used in other disease states to understand the safety and efficacy of these agents in systemic sclerosis. Another emerging therapeutic avenue are cell therapies like CAR T therapy or looking at engineered NK cells. And again, this could be another promising therapeutic option for patients with systemic sclerosis. So, the key takeaways that I want you to consider is that in terms of the phenotype of patients, this can really drive the progression of this disease, but it's also fundamentally going to change how you treat these patients. And I really hope that over the course of my career, we begin to understand how to personalize treatment for patients and really pick agents that we know not only help a broad population get better, but how one single patient can improve from a therapy. We need to balance multiple domains, so not just efficacy, but consider safety and tolerability profiles and engage with patients so we know that they're a part of that decision making process. When you understand a patient's values, their preferences, as well as their comorbidities, this can help improve adherence. So, for example, if a patient has a lot of GI symptoms related to their scleroderma, and you're suggesting that they start a medication that causes more GI symptoms, you want them to be aware from the get go about what the risks are. And some patients might be able to accept that risk, and others will say no. But if you don't talk about those issues with the patients, they can sometimes just stop taking their medication and might not even feel comfortable telling you. I think that over time, we need better ways of monitoring patients in terms of their adverse events, including nurses and other allied health professionals into this paradigm could be really important since it's really hard for one single person to do all of these things for a patient. So, how can you collaborate? This is a perfect segue into collaborating with other interprofessionals when you're individualizing care for your patients. So it really takes a village to care for patients with systemic sclerosis. You, as the rheumatologist, may be the quarterback to a broader team that are involved in helping these patients. So if a patient has ILD or PAH, you might include pulmonologists and cardiologists. You'll also probably involve pathologists and radiologists just in the diagnosis of these diseases. And then I think it's critical to include physical and occupational therapists. Many patients with scleroderma live with a lot of problems with their hands, not just the puffy fingers, but hand contractures, digital ulcers. And I find that these therapists can offer really creative solutions to helping patients maintain their hand function over time and also have diminished pain and discomfort. Respiratory therapists are critical for patients who live with lung or heart diseases. These therapists can actually show patients how they can exercise safely. Because if you have a patient who experiences, let's say, breathlessness with walking, they might start to become afraid to walk. But when you send someone to a respiratory therapist, they will do exercise with the patient while monitoring their heart rate, their oxygen saturation, and they'll teach patients what they can do safely. And this can be hugely empowering for patients on their journey to know what is okay and what level of dyspnea is okay to kind of work through to make sure they're keeping up with their conditioning. Social workers can be indispensable, especially because if you see healthcare providers in the US, you have to deal with health insurance companies, and there can be barriers to getting certain treatments or studies. And social workers can help patients navigate that process. Psychologists can also be critical here because just having a disease that can be fatal can have a huge impact on a patient's emotional well being. It can be enormously overwhelming to navigate the healthcare system and see different specialists and understand, what your prognosis is. And if a patient has someone that they can talk to and confide in, this can be helpful. I would say that some patients who live with diseases like scleroderma don't want to be a burden to their families and friends, or maybe they don't even want their family to know the seriousness of their condition, but they can talk to a psychologist so that they can have someone to share sort of these intimate fears and worries with without, being worried about how it's going to affect their family. And then dermatologists can be helpful. This is a skin condition, GI doctors as well. And then these nurses, NPs, PAs can be really helpful in the management, especially day-to-day management of the patient, monitoring for safety of medications, treating side effects, and the like. So, patients actually do better as well when they're educated about their disease. And so, I think it's really important to talk to patients in a way that they understand about what could be causing their disease. Talk to them about how we're monitoring progression because oftentimes patients will take a therapy. They might not feel any different in their body, but you will be monitoring their CT scans, their pulmonary function testing, and if you teach the patient about how you're using those metrics to determine whether the drug is working or not, a patient might be more likely to commit to taking the medication that doesn't really affect how they feel today, but might improve their longevity in the future. I think, in terms of management options, again, talking about both the pharmacological and non pharmacological options can be helpful. And then finally, this is something that I'm a big proponent of is empowering patients with things that they can do on a daily basis to improve how they feel. When someone is first diagnosed with an autoimmune disease, it's quite normal to feel like everything is out of control, that the body is betraying them, that all these things are happening that are so unfair. And a patient can really start to feel like a victim of their disease. And by teaching patients ways that they can change their diet and lifestyle, this can actually help patients regain some of that control. And I have seen patients in my career experience profound transformations in their health just by simple changes to their lifestyle. And this psychologically can improve how they feel because, again, they become less of a victim of a disease and more of an active participant in their healthcare. So, what are the evidence based non pharmacological options for patients? So, there are physical interventions, and I mentioned that working with an occupational therapist or physical therapist can be helpful. If that's not an option for patients, there's a lot of videos that exist on YouTube and other channels where they can learn these hand exercises and learn stretches on their own. There are actually people that have created whole yoga programs just for patients with scleroderma and other people with disabilities. Having a skincare protocol can be helpful because when patients get scleroderma, the skin becomes very dry sometimes and itchy, and patients can have so much itchiness that they can't sleep at night. So I talk to patients a lot about this and natural remedies that they can use. Also, there's, strategies to keep the temperature up so you don't trigger Raynaud's. And one thing that's helpful to know in the winter months is that there are actually discounts available through heating and gas companies for patients who live with Raynaud's, where they might be eligible to get a discount so they don't have to make the choice between having a higher heating bill versus having a Raynaud's attack. And then also other lifestyle modifications or simple changes to the diet that can improve reflux and other symptoms. Smoking cessation is essential, as well as different energy conservation techniques. And I try to teach my patients something that I refer to as pacing. So this is like patients often with autoimmune disease can really run out of energy throughout the day. They might hit a wall at 2 p.m. or 3 p.m. and then not be able to function the rest of the day. So I usually advise patients to kind of hold back as they start their day, even if they wake up with tons of energy, to hold back a little bit and save some of that energy. And then finally, stress. Stress plays a huge role in how our immune system functions. There's so many studies on this, and many people who get scleroderma report stressful events happening leading up to their diagnosis. And this can play a role, again, not only in probably causing the disease, but also exacerbating the symptoms. So, learning ways to reduce stress through things like yoga, mindfulness, meditation can really help patients on their journey as well. In terms of patient reported outcomes, these are the things probably that matter the most to patients. So, when we're discovering new therapies for patients, we have in mind, okay, we want to improve their lung function, we want to improve their CT scan, but probably what matters most to the patient is how they feel and function. And there are certain patient reported outcomes that we have available for this disease. I mentioned the HAQ-DI or the SHAQ. This is the scleroderma specific health assessment questionnaire. We have something called the UCLA GIT 2.0. This is looking specifically at the symptom burden as it relates to the GI tract. The FACIT dyspnea. This is looking at dyspnea or shortness of breath. And there's something called a patient global assessment where a patient just rates how they're feeling on a day-to-day basis. So these types of quality of health measures can help you start the conversation. So you could consider in your practice distributing some of these questionnaires if you want to get a objective metric every time the patient comes, or you might look at these questions and just start incorporating them into your clinic note. So how is SSC affecting your daily activities and the things that matter to you most? What symptoms are most bothersome for you and limiting you right now? Or are there aspects of your care or support that feel missing or could be improved? And some patients really feel like they're living alone and are very isolated with this disease, even when they live in a family with other people. And again, this could be because they're not comfortable sharing their experience with others. But if you are their healthcare provider, you can unearth some of these important issues that the patient may not feel comfortable talking about with anyone else in their life. So the communication strategies that might be effective are to think about, integrating some of this into the EMR. So could you have a way in your note of asking a patient before they even see you some of these questions so they could fill it out in the waiting room and have that be integrated into the EMR? There could be ways to improve how we manage patients by having specialty clinics that are co-located together. I've been really fortunate in my career to work right down the hall from pulmonologists and gastroenterologists and cardiologists who all specialize in scleroderma. This makes it logistically very easy for patients to see all of us sometimes on the same day, but it also makes it easier for us to discuss topics related to patients. So I can ask my pulmonary colleague, hey, I saw this patient today. I was thinking about doing this. What do you think? And even if you don't practice in a place where your pulmonologist is down the hall, it's quite easy to call someone on the phone, to get on a quick Zoom, to have some kind of collaboration. And I guarantee you, patients know when their different specialists are talking to each other. The referral networks are key here, and I think there's a lot of information now on the internet to help guide patients to where the specialty centers are. And one good resource is the National Scleroderma Foundation, which you can put in your zip code and look up to see what is the closest center to you. And even if you can't travel to that center, there's a lot of physicians that specialize in scleroderma, myself included, that will see people over telehealth even for a first visit. And I think telemedicine, we learned a lot about this during the pandemic, and it's helped, offer access to patients who live in more rural areas. Having a care coordinator can be helpful, and having a nurse practitioner or someone who really understands rheumatology and scleroderma, this can again be sort of a communication hub and help you gain access to a doctor and get all of your questions answered as a patient. So, to build a collaborative care framework, you need to identify the team. And so, I mentioned, with that patient case, Kevin, we were sort of cluing in to make a team for that patient, someone to help with his lungs, someone to help, monitor his kidneys, someone to help with his skin disease. And I think putting that team together at the beginning is really important. And you can add or delete certain members of the team as needed over time. You want to engage with your patients as partners. The more informed and educated they are, the better they'll be able to participate in this decision making process. But again, it will also empower them to be less of a victim of their disease and more of an active participant. It's critical to establish clear communication channels. So if you have a way where you prefer to talk to patients on the phone or communicate through a My Chart or a message system, whatever works for you, it's important to tell the patients how they can reach you, because if you're seeing the patient every 3 months and they have a disease like scleroderma, there's going to be things that come up over the course of that 3 months, and it's going to be critical that the patient can reach you. Finally, try to integrate some of these patient reported outcomes into your care and regularly assess how the team is functioning. Are the patients satisfied with the different team members? And if they're not, can you suggest alternative team members for the patients? So, the summary and key takeaways today are that SSC is a multi system autoimmune disease driven by intersecting pathways that affect inflammation, vasculopathy, fibrosis. This disease has heterogeneous organ involvement, high morbidity, as well as high mortality. If you recognize early features of systemic sclerosis, this can help identify patients at risk and enable eventually earlier intervention. The risk and prognosis are multifactorial, and you really want to consider a holistic assessment that's looking not just at demographics, but their autoantibody profile, their organ involvement currently, and what pattern they're following. The therapeutic options in the space are expanding rapidly. And I think the more therapies we have, the more opportunities we have to personalize how we care for these patients. And when you work as a team and really offer patient centered care with informed decision making, this ultimately will lead to better outcomes for our patients who live with this disease. So, I want to thank you so much for joining me today. I hope that you found this activity useful to your practice.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an independent educational grant from Boehringer Ingelheim Pharmaceuticals, Incorporated. To access all materials for this activity, visit peerview.com/TCA860.